Hello, everybody. My name is Jonathan Rasouli, and I'm a neurosurgeon at the Cleveland Clinic in the Department of Neurological Surgery. And today, my topic will be controversies in cervical arthroplasty. I'd like to start the presentation by giving a case example. This is a 36-year-old man with a past medical history of medically refractory neck pain who presented with left upper extremity radiculopathy and a C6 distribution. What you can see here on the lateral X-ray, lateral MRI, and then an axial cut through the level of the pathology on the MRI. This patient has a relatively kyphotic or straight posture in neutral alignment. On the MRI at C3, 4, 5, 6, the patient has what appears to be a soft left-sided paracentral disc herniation with compression of the nerve root in that area. With this constellation of symptomatology and findings on imaging, the patient may potentially be considered a candidate for a surgery. However, there are many different surgeries that this patient could potentially undergo. One of them is a traditional one-level anterior cervical discectomy and fusion, aka the ACDF, with the placement of an anterior plate. Another option is an ACDF procedure with a standalone plate or an integrated plate. And typically these interbodies utilize plastics such as PEEK, or they use titanium metal as the source of the bony overlay fusion, and the screws are integrated within the inner body themselves, and they go in the superior and inferior vertebral bodies. More recently, or another option, which is starting to really gain some traction, is the use of a cervical arthroplasty or a disc replacement. And in particular, with patients who have good neutral alignment and have a soft disc herniation with mostly radiculopathy, the cervical disc arthroplasty is a good option for these patients. And I'll explain to you a little bit why a little bit later in this talk, as well as some of the controversies with these devices. So cervical disc replacement or arthroplasty has been around for quite some time. It's not a very new technology. What you see here, this is just a product demonstration of what the device looks like once it's placed inside the disc space at the end of a surgery. You see sometimes these devices have a little keel superiorly and inferiorly to keep the device from backing out. And then as the patient rotates and moves their necks in flexion and extension, the device is essentially allowed to keep up with the normal movements of the cervical spine. It is considered an acceptable alternative to anterior cervical discectomy and fusion when there's clinical equipoise or when a patient presents with similar symptoms and pathologies. Currently, the data shows that it is equal or potentially non-inferior to one-level ACDF, with some industry-sponsored studies suggesting that it may be potentially superior to two-level ACDF in highly selected patients. What's nice about the procedure is that it's essentially the same surgical approach as Smith-Robinson exposure, and the primary goal is not to achieve a bony fusion. Therefore, there's less decortication, there's less end plate preparation required for the placement of these inner bodies, and the main indications for the placement of arthroplasty are neck pain or radiculopathy caused by, primarily radiculopathy, medically refractory radiculopathy caused by a single level disc herniation or potentially two-level disc herniation in the subaxial cervical spine. We ideally like to have these patients to have normal lordosis, minimal degenerative spine disease throughout the cervical spine. They should not have dynamic instability on flexion extension x-rays, and there should be minimal, if any, cord signal change or preoperative symptoms of myelopathy, and I'll explain to you why that's the case. So essentially, the best patient is a young adult with a single level soft disc herniation. Now, why have we even really considered arthroplasty as a potential option for for patients with cervical radiculopathy? And the main reason for that is that we saw that there was generally good data in the shoulder and hip arthroplasty literature in the orthopedics world. So we thought maybe we could potentially translate this over to spine surgery. So as we have seen with ACDFs, over time, and we're talking about many, many years to decades after a person undergoes an ACDF, the success rates tend to decrease and the reoperation rates tend to increase. And one of the main reasons we believe is that with the fusion of a normally mobile segment in the cervical spine, especially in young patients, the lifetime risk of adjacent segment disease is significantly higher in this population, and it may have negative long-term effects on the clinical results of cervical fusion. Now we know that adjacent segment disease is a is a rule. It's not an exception that patients generally will always develop this if you give them enough time after a fusion, but the question is whether or not these patients truly become symptomatic from it. So the thought is with cervical disc arthroplasty is that it will preserve motion at the segment in which the surgery was undertaken. There's less risk of adjacent segment disease. You don't have to use a plate, which is nice, but sometimes there's a keel, which can be a little bit technically challenging. And there may be some data suggests that it may be better than ACDF. But the cons with this is that it is technically more challenging in the sense that you are trying to avoid a fusion. So many of the techniques and tricks that we do for an ACDF, we're not supposed to do here for an arthroplasty. And the jury's still out whether or not it reduces the incidence of adjacent segment disease. In terms of the history of cervical arthroplasty, the first prototypes were developed and used in Europe with what were deemed to be good results. And this was in the late 90s, early 2000s. And as time went on, uh, newer and better devices were developed and slowly introduced within the United States. And the first device were the Prestige and Bryan devices in the United States in the early 2000s. And the early data showed that there was a pretty satisfactory clinical success rate in patients who underwent the arthroplasty placement at about 1 year after surgery. And what this initiated was a prospective randomized trial looking at the ProDisc C in 2003. And this was shown to also be relatively successful. Based on the data of these early studies, in 2007, the FDA approved the use of cervical disc replacements for the treatment of one-level disc pathology. After this, there was kind of an explosion of devices on the market. Each vendor and each spine technological company developed their own device. And with that being said, each device had their own little nuances in terms of placement and some of the uh, uh, degrees of motion that they purported to preserve. So since 2012 to present, there has been more uh, studies showing improvements and uh, generally better outcomes after cervical disc replacement. And generally, what these studies are doing are comparing the outcomes to the ACDF. And finally, in 2013, the Mobi C was approved for a two-level disc replacement and potentially showed some superiority. So, in summary, there are 6 total disc replacements that are FDA approved for one-level cervical disc pathology, and the Mobi C and more recently the ProDisc C has been approved for 1 and 2 level cervical disc pathology. So the thought is that these studies have shown there is one level discs it may be non-inferior, and for 2 level discs it may potentially be superior, which is really interesting because what we have seen is that the surgical intervention rates um, have been have been reported in these larger studies, and from a large body of patients who underwent cervical arthroplasty, who had a mean follow-up of about 2 to 3 years, the mean rate of reoperation was 1%. Now, if you remember from my previous slide, I mentioned that over 5 to 10 years, the reoperation rate for ACDF is almost 10%, and it's believed to be primarily due to the development of adjacent segment disease. And these have a very low revision rate and generally a low removal rate at about 2 to 4 years after surgery. Now, what's interesting is if you follow the trends in usage in the United States, before the FDA approval, these devices were generally slow to take traction. And you can see that the total number of surgeries that were done were a little bit less than 2,000 versus over 300,000 ACDFs in the United States. Once the FDA approval came around, there was a nearly 700% increase in the number of disc replacement surgeries that were done in the United States, with generally a stagnant amount of ACDF procedures. And more recently, this number is slowly increasing, but as you can see, there's still a general overwhelming majority of surgeons are doing ACDFs rather than cervical disc replacements. Now, if you've ever seen the Scott's parabola, this chart essentially is a good example of what has happened with the cervical disc replacement technologies. As we see in the early 2000s, there was a promising idea that was primarily done in Europe, and with these small studies looking at small cohorts of very carefully selected patients, we saw that there may be a difference and maybe potentially some either non-inferiority or superiority in results to patients who underwent 1 or 2 level ACDFs. And as after the FDA approval of these devices in the United States, there was an explosion, and basically everyone was this was very the new hottest thing. People were advertising this, and it was very popular. But as we are seeing now, as doubts start creeping in, these devices are losing their popularity, and it seems that there's a general trend towards surgeons going back to doing traditional ACDF procedures. Now, the reasons for that are complex and multifactorial, but it's something that is interesting and seems to be continuing to happen as time goes on. So, if you're going to compare the two, looking at the traditional ACF literature, the reoperation rate is about 10 to 12% over the long term, with a slightly lower reoperation rate in the cervical disc replacement literature. Now, if you see the adjacent segment disease rates are almost equal, but there is a faster return of prior life activity because there's no need for fusion in these patients. Um, in a systematic review that was published in 2018, these authors found that although the disc prostheses or the disc replacements were introduced to decrease adjacent level disease, we don't really know if that's true radiographically. And there is a relatively high risk of heterotopic ossifications in these implants. So what's new? There are more discs on the market. We have longer term results of these IDE trials, and there are more longer term systematic reviews and meta analyses. And we've learned kind of nuances of the placement of these devices to avoid developing heterotopic ossification and effusion. So as you can see, it's basically there's a some of the newer studies are showing either slightly better results with these cervical disc arthroplasties or maybe no difference. And with the meta-analyses and reviews, uh, they're essentially the same thing, that they show either no difference or possibly increased NDIs and potentially decreased revisions. However, the problem with these studies is that these are all industry sponsored. There's a lot of obvious conflicts of interest with hypothesis driven research, and there are certain expectations or biases that are introduced with patient expectations in these trials. So while there are other more non-biased studies that have been published looking at the Swiss and Swedish registries, a lot of them show that there was essentially no difference between ACDF and cervical disc arthroplasty. So some of the things that we wonder, does disc replacement restore motion? What about heterotopic ossification? Does it change alignment? And do the 2 levels do as well as one? Some other question is whether or not these devices are indicated in patients who are myelopathic. So if the disc does not move before disc replacement, then it really doesn't move after surgery. And these motions are maintained but not increased at 10 years. Additionally, we don't really know if these patients really develop significant changes in their alignment from pre-op and post-op. So if they're kyphotic pre-op, they generally remain kyphotic post-op. Data is kind of out on 2 level disc replacement, and it shows that for patients who have myelopathy, some of the early results show slower recovery in myelopathy, but no difference from fusion. I'll skip this slide. One of my favorite papers that I want to kind of end on is this paper with Alvin and Miraz and some of my colleagues at the Cleveland Clinic, where they actually showed that when the potential perceived conflicts of interest where authors were removed from the studies that looked at arthroplasty, then there was absolutely no difference between the rates of adjacent segment disease compared to ACDF. So this was one of the first critical reviews to show that once you remove authors who had a perceived conflict of interest, there was no difference between ACDF and arthroplasty. So it's something to really look at. So in summary, the jury's still out for cervical arthroplasty versus ACDF. and there's still some more work to be done. I thank you very much for looking at my presentation, and I look forward to any questions that may be coming up later. Thank you. Bye bye.